one thing about the bill I think is a legitimate, can be criticized for, is that they didn't really provide an answer for, well, wait a second, if you're saying they can't get on Medicaid, where are they supposed to get health coverage?
Welcome to Hospitals in Focus from the Federation of American Hospitals. Here's your host, Chip Kahn.
With the passage of the One Big Beautiful Bill Act, Congress has taken a major step towards reshaping large parts of the nation's healthcare coverage through cuts, restrictions, and regulatory changes that set us in a new direction. The OBBBA's most consequential provisions, like work requirements and provider-related cuts, are not going into effect until 2027 and 2028, leaving room for uncertainty and political recalibration. As we look to what comes next, what are the prospects for meaningful health reform? Is this a retrenchment on Medicaid and Obamacare, or the start of a deeper policy shift? And where do we go from here to assure a more stable, sustainable system that supports patients, their coverage, and the providers and clinicians they depend on for their care? To help us unpack these questions, I'm joined today by Jim Capretta, Senior Fellow at the American Enterprise Institute. Jim is a veteran policy expert who brings a long view to developments in healthcare policy, not just on what's in the OBBBA, but what it reveals about the current direction of health reform and the fault lines that continue to divide the public, parties, and policymakers. Thanks for joining me today, Jim.
Thank you, Chip. I'm really glad to be with you on the program. So thanks for having me on.
Jim, just to get things rolling, a lot of major health legislation over the years has moved the dial on coverage, on healthcare programs. What has the OBBBA done in your mind in terms of the health aspects of the legislation?
Well, I would say the health aspects were, in a sense, pursued to achieve the other objectives that the sponsors of the major legislation were trying to pursue. Really, let's be honest, it was the tax provisions that were driving this train, and some fiscal concerns attached to the tax provisions, which led the Congress to look and think through, where can we find savings? Of course, the big entitlements, Medicare and Medicaid, are where all the money is. And in some ways, it became the de facto, the default way of going about it was to go and look hard at Medicaid, because Medicare, in a sense, was taken off the table. So Medicaid became the focus of trying to find a lot of savings to help the tax objectives get across the finish line. I think that's really what happened politically.
Jim, that's a very interesting point you make, and I think harkens back to earlier periods years ago, before Obamacare, before the Medicaid Modernization Act, when there were many budget bills, and I used to say that the healthcare provisions were the tail, not the dog, whether it was deficit reduction or tax cuts, they were really the driving forces. But whatever the motivation for the inclusion, and even with the objective of deficit reduction or spending reduction being part of it, this still was a very big health initiative, and probably changes the nature of the Medicaid program, and clearly will have a significant effect on the operation of the marketplaces. I'm going to separate those two and allow you to take a second to try to unpack on the Medicaid side what you see as the significant aspects of clearly not just the largest Medicaid cuts in history, but maybe the largest changes in the basis of Medicaid we've seen in a very long time.
Yeah, I think there were really two very consequential provisions enacted. There are obviously many in the bill affecting Medicaid, but the two most important, of course, have gotten a lot of press attention, which one is the work requirements, which is the first time Medicaid, at least in statute, now has a provision saying that anyone who's entering into the program not through the old channels of being disabled or, categorically eligible based on their status, but just has a low income and otherwise is uninsured and wants to get insurance through Medicaid. For that able-bodied population, put that in quotes, the law is requiring some participation in the workforce or other activity related to participation in the workforce at a level of, I think, 80 hours a month. So that's a big change, and it's an expectation expected in the community that many millions of people will be screened out of the program based on that expectation. I think part of the difficulty we've had in debating this over the last several months is some lack of evidence and confusion about what will happen if you do this. Many people say that the requirements actually aren't that hard to meet because you can volunteer, you can go to school, you can do other things to meet the requirement. But a lot of other people say, well, yeah, but when it's been tried, it ends up being just a block, a paperwork block. And therefore, many millions of people will become uninsured because they won't be able to jump through these hoops, so to speak. So I think some of it, remains to be seen about how it plays out state by state. But there's no question it's a major shift in policy. And, there's a lot of aspects to it that can be debated. Should the country be conditioning health insurance enrollment based on participation in the workforce, or should people be able to get health insurance? Maybe that will help them stay healthy and then they can go back to work. Of course, there are arguments in both directions on that. That's one. The second big provision is the one that's going to affect the provider community even more directly, which is changing how the states are allowed to raise their share of the money to pay for provider payments. So-called provider taxes, supplemental payments. These were tightened up very substantially going forward, back-ended though, so that they don't kick in for quite a number of years in terms of their real pinching, in terms of how much they're going to affect the states. But if they do remain in place, they'll force the states to adjust quite substantially to how they pay providers and also how they raise money for their share of the costs. So overall, I would say the bill is has those two aspects to it, which means it'll be harder for people to sign up for Medicaid without working. And it will be harder for the states to finance Medicaid through provider taxes, which in effect can kind of ease their burden and put more of the burden on federal taxpayers.
We also saw some changes in the marketplaces that led to some savings that were included in this legislation. The changes in Medicaid, as well as these, were under the guise of waste, fraud, and abuse. But do you believe that the impact of the program integrity changes included in the bill, and actually there was also a recent regulation, will affect the numbers in terms of those covered? Will it create sort of obstacles too? Like, in a sense, you're saying we could have obstacles on the Medicaid side regarding work or re-verification of eligibility?
I do. One person's obstacle might be another person's, and program integrity check, kind of thing. So I don't mean to make light of it, but there are always going to be rules around which you enter into public programs that, in effect, provide taxpayer support to various, households. The question is, how tight do you make them? How narrow is the window? And, to be honest with you, there's been, over the last 10 years or so, a lot of liberalizations that made it easier and easier to get into the marketplaces, to get it into Medicaid. And there's no doubt that program enrollment has soared on both sides. So the uninsured rate came down by, 15 million, 20 million people. But the number of people on Medicaid and on the premium credit programs was multiples of that, meaning that some people who were otherwise covered in other ways prior to the ACA being enacted have now migrated into Medicaid and the premium credit structure. And the question is there a balance to be struck? The people who wrote the bill wanted to be very tight about it. But people who oppose the bill say, hey, you're going overboard and you're going to push a lot of people out who can't otherwise be insured any other way. So some of this is going to have to be, debated, I think, continually going forward. maybe some of it implemented and then adjusted over time too.
One of the problems here is this. I mentioned waste, fraud, and abuse. One man's waste, fraud, and abuse is, getting to goals of more coverage. Another is an abuse of what the taxpayer intends his or her funds to be used for in public policy. Going back to the balance question, how do we, assuming that we want everyone covered and that we want everyone to the extent possible covered in the private sector, albeit that public funds may be involved. Do you have any ideas how we get to that balance? How can we work our way through this ideological battle we have over how we do something that we know is good for everyone, which is healthcare coverage?
Yeah. I mean, I think the big difficulty here, Chip, is that they took the valid objective, which was to say, the public budget, the federal budget, is overburdened with medical care spending. Medicare and Medicaid are quite expensive and have grown very substantially relative to our tax base over the last half century. So, and they're expected to continue to grow. So, it is a legitimate public question. How do we deal with this? What is the answer? My problem with the way they proceeded with the bill was they then said, well, we can cut a lot of spending if we make it harder for people to get on Medicaid and the premium credit structure, which I think is sort of the wrong way to think about it. They should have maybe been thinking about how do we bring down the costs of enrolling in insurance so that it's less expensive both for the federal budget and for private payers out there to secure insurance and get medical care services. That's an entirely different and much more difficult question than just saying who's eligible for signing up for public subsidies, which if you tighten that up, one thing about the bill I think is can be criticized for is that they didn't really provide an answer for, well, wait a second, if you're saying they can't get on Medicaid, where are they supposed to get health coverage? And of course they say, well, they need to go to work, I think, but, depending on someone's life circumstances, that may or may not happen. And so what happens then? So I think a lot of this gets down to lowering the overall bill for medical care expenses, which would then allow bringing down both Medicare and Medicaid costs. I think it was a mistake also, by the way, to focus entirely on Medicaid and not bring into the equation, are there ways to save money further in Medicare, which is an even bigger program and frankly, directly under the control of the federal government.
I want to drill down a little bit further into the points you're making now, but before I get there, I guess I have to ask the question, do you believe these reductions, at least the ones regarding Medicaid, are actually ever going into effect? And why do I ask that question? Well, if we look at Obamacare, it included reductions in what's known as the disproportionate share payments inside of Medicaid. Those have gotten pushed off every year, those reductions. And here we have legislation, as I mentioned in my introduction, that doesn't, major portions of it don't begin in the Medicaid reductions until 27, 28. So that leaves a lot of time for advocates to go to their legislators and say, well, hey, wait a second. Do you really want to do this? Even though the bill is passed and signed into law. How do you see that playing out? Is this just too big to change, or do you think this could get changed and put off?
I don't think there's any question it could get changed. First of all, they wrote a bill that has some of these provisions won't take effect for even beyond out in 2030, 2031, So there's a lot of things scheduled way out in this bill. And, a lot depends on elections. In this country, it's still a big factor in all of this is who wins the election. And so you have a midterm election in 2026, another presidential cycle in 2028. Both of those elections could have major effects on not just what passed here in 2025, but what they propose going forward. Let's assume, Republicans kind of stay in the power position here for a little while, maybe 5 years. If that's the case, then these cuts or some modified version of them have a pretty good chance of going forward. If the fallout from them turns out to be substantial, as many people think they will be, then of course, once that happens, they might start losing elections, but that could be well down the road. So I think you're on to the right track here, Chip, which is that elections have consequences, and we got a couple that might still affect what happens here, going in through 2028.
Let's assume for a second, though, that these cuts do take effect, at least the major ones. And there has been, some discussion about, particularly in the expansion states, which is most of the country, those Obamacare expansion states in Medicaid, that this is really all about, and the work requirements are really all about, mid 20-year-olds in their parents' basement playing computer games, being covered by Medicaid and not working. Well, frankly, if that's the case, those people probably aren't going to be sick and use healthcare dollars anyway. A lot of these people who will, fall through the cracks because of these changes are still going to require healthcare, and they're going to show up at hospital emergency rooms or community health centers or whatever to get their care. How is that going to play out if we assume that these cuts will go forward, even if it's a year and a half or 24 months away?
I think part of the confusion here is that Medicaid doesn't have a disability definition that really fits with the way the debate played out. People were saying, well, if you're able-bodied, that means you're not on Medicaid because you're disabled, really. Therefore you can go to work. But of course, as I think your question, Chip, is pointing at, there's an awful lot of people who end up on Medicaid. They don't qualify for Social Security Disability or SSI, which means they don't become categorically eligible for Medicaid, but they might still have a lot of health problems that hold them back a little bit in terms of employment and earnings, and certainly makes it difficult for them to secure health insurance outside of a public program. So I think is going to be where much of the controversy is going to center. People who are diabetic and maybe struggle to manage it for any number of different reasons, people with mental health problems, substance abuse problems. Many people could end up on Medicaid for reasons other than being fully and totally disabled. And so, yeah, I think you're right that a lot of that care and coverage will still be provided, and there'll be pressure to figure out a new system to make sure these people can be taken care of if they're not allowed to stay on Medicaid. Now, having said all that, I do think once this became federal law, which it now is, that you have to meet these work requirements to stay on Medicaid, the states are really in the driver's seat in implementation of these provisions. So some states may find ways to make it as easy as possible for people to stay covered. And I think a lot of the states that really care about coverage will do so. And so it's not totally clear yet if a state like California or New York or some other place, if they want to, they might be able to retain much of the coverage they have today by helping the people meet this requirement in any number of ways.
I'm going to ask a question, and then I'll go big, a small question, and then I'm going to go big. So my small question is, with all these changes that have taken place or will take place because of this legislation, with the predictions by Congressional Budget Office of tremendous loss in coverage because of these, in that context, how do you see sort of the one big healthcare issue in coverage that didn't get settled here playing out, and that's this enhanced premium tax credit that was put in a few years ago, that I think over half of those on the marketplace coverage take advantage of today. I think half have almost no premium at all. That expires at the end of 25. How do you see that playing out in the fall, looking towards sort of a last chance to get that extended? Do you think there's a chance that could be extended even with Republicans' concern over Obamacare and the marketplaces and spending generally?
I do. I think they could be extended. I'm not guaranteeing they will be, but I do think it's possible. I mean, candidly, I didn't support the bill for fiscal reasons. It was a major budget buster, frankly, for a lot of reasons. But I also didn't really like what they're doing in healthcare, mainly because I think their attitude about coverage is all wrong. I think for the last several years, I've had the exact opposite instinct to what motivated this bill, which is we ought to be building a system that isn't so complicated in terms of securing coverage. It ought to be easier, more straightforward rules based on real data and real income data. And you get placed into the various buckets based on hard earnings data, not estimates, not projections, not, possibilities. But what did you earn for the last 6 months? Therefore, here's what you get. And you get it for an extended period. So you don't have to worry about it for another 12 months. I think that would be a much better system. That brings me to your question, which is with these tax credits expiring at the end of this year, I think the Republicans, if they were on their toes, they would say, hey, this may be our most high leverage point in recent history to change how people get subsidized into coverage. If they don't like the marketplaces, if they don't like the premium credit system, they could use the money that is expiring and say, hey, we'll work with the Democrats on a new way to make sure just as many people get covered, but in a way that we like a little bit better. If they want them to go into employer plans more, design a new way to support that. If they want more individual insurance enrollment outside the marketplaces through HSA-based, high deductible plans, find a way to do that. I think there's ways they could take the impulse to extend those credits, which is very powerful, and say, hey, we'll work with you to design something that isn't entirely just the ACA model, but tries to extend coverage to this population through several additional channels, including trying to keep as many people as possible in employer plans, if that is a possibility.
So let's build off of that. I mean, in a sense, you're giving us the beginning of your vision of where we ought to go on the coverage side. And let me sort of hit with the two big themes here from our conversation. One is we really want all Americans covered. We can talk about how it's achieved, but that's a positive end so that they have financial security that protects them against healthcare disaster or catastrophe for themselves or their families. And on the other hand, the federal government over the years, whether it's through Medicare, Medicaid, the Obamacare aspects, even the tax system that provides incentives for employers to provide coverage, that tax exclusion of employer-provided coverage. We have this tremendous subsidization, and frankly, the country has a spending problem. How do we bring all that together, in your mind, to have a more sustainable system? Because people really should deserve and expect good health care and certainty about their access to health care. And that access really depends on having coverage, because you've got to be part of a group, whether it's a private group or a social insurance group. Most of us can't afford any major healthcare expenditure. We need to be part of a group. Fortunately, most of us are not sick at any given time. So the group can help us afford that, whether it's private or public. How do we make all that work?
Well, that's sort of a half-century long struggle, as you know better than most people.
Yes.
So yeah, people have been working on it a long time. And, I would say we've been making some progress here and there. It's like American healthcare is one of those frustrating exercises where we do a little good here and a little good there. And we also have some disasters here and there that kind of set us back. So it's always a mixed bag. But let's take a big picture look. We're at about 18% of GDP on total spend on healthcare. Most of our peer countries are at about 12. They probably should be at 13 or 14 if they weren't over-regulating their system. But we're a big, rich country. And so it's probably not unusual that we spend a little bit more on health, which is a preferred good. That is, when you have more money, you tend to spend more on something like this because it's very highly valued. So the fact that we're spending 18 or 19% of GDP on it and not 12 or 13 isn't the end of the world, but we probably are wasting a few percentage points still. We'd be better off. We'd all feel better if we were down at 16 or 15 rather than 18 or 19. And we probably could be at 15 or 16 if we were more efficient and disciplined about how we went about things. I think we all know there's a fair amount of leakage out there. Yeah, it's a good system by and large. And it's pretty efficient in certain ways, but there's a lot of excess. I mean, people getting the same test, 2 or 3 times in a 3-month period, right? Or just because the records are never kept up, and clear, and they move around, and it's fragmented, and lack of coordination, and maybe overuse of certain services. And people are in poor health too. And how do we have interventions that kind of slow down that deterioration rather than waiting till they're really, really sick? So all of those are opportunities to bring more discipline to it. My thought has always been that to help that happen, we need 2 things. One is we need a little more structure to it. I think there's a little bit too much confusion and lack of transparency and difficulty in navigating through all this, which makes it very hard for payers, that is employers, but also just people, individuals, to find ways to kind of lower their own bills a little bit. And I think we ought to be putting more structure around the marketplace, not hard rules like I don't want to micromanage things. I want more rules around pricing and make it more clear to people when they could get better value by migrating to a lower cost setting. I think that's critical. And but it's, as you know, Chip, better than almost anybody, really, it's very hard to do for a lot of reasons. And but I think it is critical. I do think we need to help both the employer community and those they are serving, individuals, and those in public programs, to help them lower their own bills, which would also lower the public bill.
Well, I guess we can hope for a better day in terms of the policy process, because we, seem to be in this great political divide, and Obamacare, healthcare, since 2009, 2010 particularly, has been part of that great political divide. And not sure that even if people agree, you can get them to consensus, because they seem to want to just disagree for general principles and for other agendas. But at the end of the day, I'm with you. We've got to find some way to make the structure more rational, and then all of us are going to have to agree that we can't spend quite as much money as we do, and accept the limitations, which will be few, but the limitations that come with that. So with that, really appreciate you coming today, Jim. And I think this conversation, sort of went from the specific of this legislation to the general that we've been talking about now. But I think we've at least laid bare some of the big issues that will have to be faced in the upcoming years, I think, by policymakers.
I agree very much with that conclusion, and I appreciate you giving me the chance to share my thoughts.
Great, Jim. Thanks so much. Thanks, Jim, for joining Hospitals in Focus today. What we're seeing in the OBBBA isn't just about policy mechanics. As we've discussed, it's about deeper questions of direction. Are we going to build a sustainable system that protects access and supports providers, or are we going to keep swinging from one extreme to the next? Frankly, coverage can't be assured and costs can't be sustained without a stable, coordinated framework that reflects the real needs of patients and those who provide care. Policymakers must look beyond short-term wins and start asking the harder questions. What's the vision? What's the purpose? What's the end game? And how do we build a system that works for all Americans and at the same time is affordable?
Thanks for listening to Hospitals in Focus from the Federation of American Hospitals. Learn more at FAH.org. Follow the Federation on social media at FAH Hospitals and follow Chip at Chip Kahn. Please rate, review, and subscribe to Hospitals in Focus. Join us next time for more in-depth conversations with healthcare leaders.